Hello, everyone, and welcome to this FIP online panel called Winter is Coming, Influenza Vaccination in Times of COVID-19, Best Practices from the Southern Hemisphere. My name is Gonçalo Sousa Pinto. I'm lead for practice development and transformation at FIP, the International Pharmaceutical Federation, and I'll have the pleasure of moderating this online panel and introducing the topic of today's webinar and also the speakers that will be joining us throughout this event. First of all, we would like to thank Sanofi Pasteur for funding this online event through an unrestricted educational grant. And just to start with some house rules. So first of all, the webinar is being recorded and it's also being live streamed via Facebook. Let me just turn my camera on so you can see me, I think. The recording will be available on our website. It will also be available on YouTube, on the FIP channel, and also on Facebook, at the FIP page on Facebook as well. Please use the questions box, the Q&A box that you will see on your screens for asking any questions that will be addressed by the speakers at the end of the webinar. We'll have approximately 30 minutes for answering your questions, so feel free to type them there. Please do not use the chat box for questions so that we can keep a log of all the questions at the end. Okay, so please use the Q&A box rather than the chat box. You're welcome to provide feedback on this webinar, whether you think we can improve it or if you found it valuable, to this email address, webinars@fip.org. And we do invite you to become a member of FIP at this website that I'm showing on the screen. As an individual member of FIP, you will have access not only to this one, but to a whole library of webinars, past webinars, and also our library of publications and other benefits that you can see there. So to give you an overview of today's webinar, I will just give a brief introduction to the subject, and then we will have three presentations from South Africa with Mariet Eksteen, Bettina Caponi from Argentina, and Andi Shirtcliffe from New Zealand that will bring some insight from three different countries in the Southern Hemisphere on how we may secure effective implementation of pharmacy-based influenza immunization campaigns in the context of the current COVID-19 pandemic. We will then have 30 minutes for Q&A, as I mentioned, and then we'll finalize with a wrap-up and a few take-home messages. So the seasonal influenza represents a significant burden. Even without the COVID-19 pandemic, it represents a significant burden of disease for health systems, and it's a risk for several population groups, including older adults, pregnant women, people with underlying conditions, several non-communicable diseases, and other groups. And in what we've seen is that in a large part of the Northern Hemisphere, the COVID pandemic reached its peak in spring when the flu season was already subsiding. So the two diseases did not really coincide in time to a great extent. But we'll see that's not entirely true. It's sort of generally true, but there were important exceptions to this. But until we have actually a vaccine for COVID-19 available and mass immunization has been achieved, the risk of both viruses circulating and leading to combined morbidity and mortality is very real and cannot be neglected. So what can we expect as the pandemic of the COVID-19 pandemic evolves and the flu season comes back again? And how can the epidemiology and the biology of these infections inform our strategy and our preparation for the coming flu season? Based on this a recently published paper by Benjamin Singer, Singer identifies several factors that will determine the overall severity of the upcoming respiratory viruses season and can inform our strategies and our preparation for the flu season. And I mean, of course, we will hear the experience from the Southern Hemisphere, because the flu season is now arriving there or coming soon. And so these countries that did not have such a heavy burden of the COVID-19 pandemic so far, but have had to prepare more quickly for the flu season that was coming sooner to their side of the world than ours. So we organized this webinar to share these best practices and these plans for the flu season, and to inform our own strategies in the north, but also, of course, in other countries in the global south. But as I was saying, there are these several factors that will determine how severe the upcoming, not only the flu season, but the upcoming season of respiratory viruses can be. One of them is, of course, the transmission modes. Both viruses are predominantly transmitted by respiratory droplets, and as such, the preventive measures to actually prevent both diseases are quite similar, including social distancing, the use of masks, and other personal protective equipment. So one strategy for this is to continue emphasizing, of course, the importance of these preventive measures, and pharmacies in close contact with their communities have a strong role in this public health domain of reducing transmission, because this will lead to a reduction of the number of cases and flatten the curve for both diseases. Another important factor is co-infection. Co-infection with another respiratory virus occurred in over 20% of the COVID-19 cases registered in the USA only. So as you can see, what I was saying before, that the two diseases did not fully overlap, it's not entirely true, because we've seen that a significant part of the COVID cases also had co-infections with other respiratory viruses. And of course, this co-infection has consequences in terms of diagnosis, in terms of the clinical management of these patients, and in terms of their, especially, and this is especially important in areas where testing capacity may be limited. So the need for accurate, rapid tests for COVID-19 is really pressing. The other, another factor is the social determinants and the disparities that we've seen in the COVID-19 pandemic, with certain minorities being particularly hit with much higher prevalence among those population groups than in the overall population. This includes ethnic minorities, but it also includes, for example, the elderly or the poor. So this also exposes the need for public health strategies and investments in reaching out to these groups and ensuring that they are adequately protected from the disease and adequately served in terms of healthcare and vaccination. And finally, the fourth point, or the fourth factor that will determine the overall severity of the upcoming season will be vaccination strategies, of course. And as we await for a vaccine for COVID-19, what we need to put in place is a plan to mitigate the overall burden of respiratory disease, using the arsenal that we have currently available, which is the flu vaccine, and by reducing by reducing the incidence and the prevalence of flu through higher vaccination coverages for flu, particularly for older adults who are, of course, at higher risk for both diseases. So following this introduction, it is my pleasure to introduce the real experts here. And we'll start with a view from South Africa with Mariet Eksteen. Mariet is the lead for professional development and support at the Pharmaceutical Society of South Africa. She's a pharmacist since 2008 after graduating with a bachelor's and a master's degree from the Northwest University. She has worked in hospital pharmacy, community pharmacy, and university, where she obtained a PhD in health professions education in 2017. Mariet is also, as I said, the Professional Development and Support Officer at the Pharmaceutical Society of South Africa, which is a very active member of FIP. And she's an individual member of FIP since 2008. And she has served as the chair of the Young Pharmacists group of FIP and is currently the global lead for pharmaceutical workforce development goal number 7, which is related to service provision and workforce education and training of the FIP Workforce Development Hub. Finally, Mariet is an elected member of the South African Pharmaceutical Council for the period between 2018 and 2023. It is my pleasure to give the floor to you, Mariet, for your presentation. Thank you very much.
Good afternoon, Gonzo, from me in South Africa. It's lovely afternoon with us. And good morning or good evening to all the colleagues that is joining this presentation, this webinar. Thank you for the kind introduction. And yeah, it's a privilege to be here and to be joining all of you. There we go. So colleagues, thank you. Let me just go back. Yeah, thank you. So I'm going to be sharing a view from South Africa in terms of this best practices from the Southern Hemisphere. So maybe just as a start, excuse me for double clicking all the time, just as a start to give you an indication of the picture in South Africa, is that we currently have a 59.3 million population, and we also have a two-sector healthcare system. So we still have a private healthcare sector or a system, and we have a government-funded public health sector. So I think it's important to understand the scope of my presentation to know that there's a big difference in the population that's covered by these two sectors. So roughly, the private sector is covering only 16% of our population. So this is, for instance, citizens that can afford private health insurance or medical aids, or who pay out of pocket for medication. And then in the public health sector or government sector, they cover 84% of the population. And so this is through government systems, government structures, clinics, district and public hospitals. However, if we look at the total health expenditure, we'll see that it's much more, almost a 50-50 break. So the private health sector will spend about 46% on that 16% of the population. And the public health sector will spend about 54% of the total health expenditure will be spent on 84% of the population, which might create the idea that it's an equal spend. But if you take the population into account, you'll see that there's a massive difference in the per capita expenditure from 15,000 rand, South African rands in the private sector per capita, and only 3,500 South African rands in the public health sector. So it's a very, very big difference in the two systems, and this is a challenge currently for South Africa, and we aim that moving towards universal health coverage, that we will more equal this difference, this current difference that we have. So in terms of the administration of flu vaccines, there's also a slight difference in the healthcare professionals that perform this duty in the two different sectors. So if we again look at the private healthcare sector, pharmacists, we have vaccination rights in South Africa. So we offer the flu vaccine as well as a number of other vaccines in pharmacies. Also in South Africa, we may employ nurse practitioners in our pharmacy clinics who can also perform vaccinations. Patients may also decide to visit their general practitioner or even specialists who, for instance, a pediatrician is allowed to offer vaccinations, or specifically the flu vaccine, or even nurse practitioners in those setups or practices. On the other hand, in the public health sector, this is purely a nurse-driven initiative, and it takes place in primary healthcare clinics, in community health centers, outpatient departments, or even in district hospitals. So the priority patients for flu vaccines has been for a number of years, generally patients over the age of 65 years, pregnant patients, and patients who suffer from a list of chronic conditions, as I've listed. Typically, it will be your asthma or your lung-related infections or your COPD, diabetes, and coronary heart disease, as an example. So these high priority patients will typically, in the private health sector, will be notified by the medical scheme or the health insurer that they are a high-risk patient and that it's recommended that they get the flu vaccine annually. So the medical aides will liaise with certain community pharmacists who will, on the behalf of the insurer, contact these patients and invite them to the pharmacy to obtain this flu vaccine. And the cost is, in most instances, paid by the medical scheme, and it's as a health benefit. So it doesn't cost the member anything. Otherwise, there's also patients that decide or choose to pay for this out of pocket. On the public health sector side, patients will visit the public health or the primary healthcare facility, and only on the visit they will be screened, and if they meet this criteria of a high-risk patient, the option of vaccination will be brought to their attention, and if they agree, they will receive the vaccine. So there's no really the same level of interaction from the public health sector to their patients to bring to their attention that the flu vaccine is available and that they can come and obtain it at the facility. In these cases, it's offered free of charge to patients in the public health sector. So if we have a brief look at the statistics from 2019, so this is our pre-COVID statistics, and I think it's very important in order to just give you, in order to compare apples with apples, if that's even possible in the time of COVID. So in the private health sector, I'm giving you a few years, 4 years, to give you an indication of the doses or the number of vials that we obtained in South Africa. So remember, this is for the private healthcare sector, and that's only actually for that 16% of our population. And there you can also see the growth percentage year on year. So in 2017, there were a lower number of vaccinations. 2018, there was again an increase. And in 2019, there was also a slight decrease. If we look at the public health sector, remember this is the sector that look after 84% of our population. And it's also indicated here per province. South Africa has 9 provinces, and each of the provinces have their own, there you go. Each of the provinces have their own budget. So they'll do their own procurement for the flu vaccine. So in 2019, you'll have an idea of the number of units that were procured, as well as the number of units that were utilized. And in the table at the bottom of the slide, I've just given you an indication of actually the total population in a province related to the global or to the South African population, so that you can compare the number of vaccines ordered compared to the number of citizens in that province. So you'll see that the public health sector has obtained just over 1 million units for the flu vaccine in 2019. So catering for about 84% of the population, they've actually sourced just a couple or 100,000 more units than the private health sector. So if we look at maybe bring COVID into the picture, I would like to share with you just briefly where South Africa is in terms of COVID. And this is our official statistics as published yesterday for the 1st of July. So as I've said, South Africa have 9 provinces. We have just less than 160,000 positive cases, of which 76,000 has recovered. we've got 2,700 total deaths. And for yesterday alone, we had 8,124 new cases added. So definitely South Africa is in that big growth curve at the moment. We are still in a level 3 lockdown. We came out of a level 5 that lasted for 5 weeks. Then we went into level 4, that was another month. And we're currently in week 5 of our level 3 lockdown regulations. So definitely on the going up. And this is something that is not ideal, given that we're entering our winter season at the moment. So let's look at what happened now that COVID is here, and how some of the regulations or some of the ways we are doing flu vaccine has changed. So the first thing I would like to notice is that the National Institute for Communicable Diseases issued an influenza recommendations for the diagnosis, prevention, management, and public health response in terms of influenza. And it's for the first time that it was highlighted in this report that it is mandatory for all healthcare professionals to be vaccinated. Second to this, there was also a guideline on influenza vaccinations for 2020 that was published by our Deputy Director General for Communicable and Non-Communicable Diseases, which also highlighted that it's mandatory for healthcare professionals to be vaccinated. So I think this is definitely a big improvement in South Africa, and I feel a sense of, for the first time, there's really appreciation for healthcare workers, or on the other hand, if healthcare workers should fall ill, the impact of that loss in healthcare work capacity or workforce is realized. And I think that is a really big improvement for us going forward. So let's have a look at how the current vaccination statistics for influenza is in 2020. So in the private sector, a few slides ago, I've highlighted that in 2019, just less than 900,000 vaccines were sourced or procured for the year. To date, in the private health sector, we've just have more than 1.3 million that's supplied. And that is equal to a 47% increase year on year. So that is the increase in the private health sector, keeping in mind this is 16%, serving 16% of the population. And personal communication confirmed that they think the true demand, so as you know, when you source or procure your vaccines for the influenza season, this was already done in December of 2019, before COVID showed its first case or became known to the globe. So based on previous statistics, order is placed for the number of vaccines that the section think they will need. And as COVID arrived, there was a need for more and more vaccines, but only so much vaccines are available. So that's why the true demand could be more, around 1.5 to 1.8 million doses. If we look at the public health sector, in 2019, it was just over 1 million doses that was procured, and just less than 1 million that was utilized. So as I've mentioned, each of our 9 provinces order according to their budget. So in December 2019, an order for 1,062,000 vials or doses were ordered. So that's a 5.6% increase. The tender company, however, sourced 1,084,000, and that was delivered in February 2020. By March 2020, our National Department of Health actually ordered or queried for another 2 million vaccines, and that was not possible. So although the tender company and other companies try to source as much as possible vaccines, either from neighboring countries or Southern African countries where it was possible to access more. So at the end, a total of 1.3 million vaccines were sourced. So this is a significant increase, as you can see from the initial order in December 2019, but also increase year on year in the public sector as well. So maybe after I've shared all of this information with you, what did COVID-19 change to our 2020 flu campaign? So as you can imagine, being in COVID-19 since, and our lockdown was initiated on 26th of March 2020. A lot of energy went into managing COVID, and also we tried to keep patients away from healthcare facilities in a number of ways, by giving them multiple months repeat of their chronic medication, or rather having them phone in for advice rather than to come in advice. So that changed the way we do our campaigns in terms of flu. So I think the first thing that changed was that it's mandatory for healthcare professionals to receive the influenza vaccine. And I know most of you could not fly, not even locally or internationally, or your airports are starting to open up. But we all are familiar with the phrase that when the oxygen masks pop out, first put on your own mask and then help others around you. And I think this is so applicable when it comes to the vaccination for influenza of healthcare professionals, that the healthcare workforce cannot afford not to be available to serve the patients. Secondly, Gonzo, I do believe that we might have reached the anti-vaxxers or where there was vaccine hesitance before, because I think everybody is so anxious to get COVID-19 or a COVID or a corona vaccine that this might have been a way that people realize the power of a vaccine preventable disease and the power of a vaccine in a case like this. I think thirdly, I would like to highlight that, and I also must say for the first time actually, that a Minister of Health has acknowledged the role of pharmacists as being the most accessible healthcare workers. And he did this on the Twitter platform. I've included 2 images. And I think for us as a profession, it's sad that it took something like COVID to bring this message across. But pharmacy really had an opportunity and a very big role as an essential workforce to play during this time. And we will continue to play this in future. And then lastly, I think COVID has also bring a lot of awareness towards preventative measures, which in my mind was always supposed to be there. And things like washing hands properly, sneezing, coughing in your elbow, and things like that is known to us. But it's sad that we had to use this opportunity to train the public as well and our patients on a number of preventative measures, not only to prevent COVID, but I believe will also impact in the way we manage our flu campaigns and our flu seasons in future. So colleagues, I think it will also be appropriate for me just to raise a few vaccination concerns that we have, maybe not only in South Africa, maybe you have it in your country as well. But we've been notified that the national immunization rates for children under the age of 5 have dropped dramatically. So you'll see, again, in our private healthcare sector, and this is only mentioned from one specific private corporate pharmacy group, is that they saw a drop in 8% in March. So remember, March we were still open until the 25th of March or the 26th. So on 27 March, and this year we went into our lockdown. So as a result, there was a 41% drop in April, a 26% drop in May, and a 40% drop in June in terms of vaccinations done year on year. In the public health sector, they saw, where last year, April, there was an 83% coverage of vaccinations, it dropped to 61% in April 2020. And so there's a fear for the outbreak of childhood infectious diseases, such as measles. As there was a drop from 77% to 55% year on year in April in terms of that second dose immunization for measles vaccination. So at the Professor Nadi at the University of the Witwatersrand made a very clear statement that children are at a greater risk of dying from vaccine preventable diseases than contracting COVID-19. So I think there's a number of reasons for this drop. Patients or the public were encouraged to stay at home, although they were encouraged to visit, or they were allowed to visit healthcare facilities. There was still some hesitance, maybe there was fear, and that resulted. So this is a really big concern for us and something that we as a country need to manage going forward. To close off, Gonzo and colleagues, in South Africa, for pharmacists, although we have vaccination rights, we're currently at a rate of only 4.5% of influenza or vaccination coverage in South Africa being done in pharmacies. So I think for us as a country, and definitely for us as the pharmaceutical society, it's important that we have to focus on a project to look at pharmacy-based immunization. And we have support of a partner that will work with us on this. And it is to increase the number of vaccinations done in pharmacies, specifically during the influenza season. So definitely, although we are doing and contributing to this, we are definitely not yet at an optimal pace where we want to be. So colleagues, thank you very much. This is this is what I would like to share with you from South Africa. Thank you for the opportunity. And thank you, Gonzo. Let me just maybe acknowledge a few colleagues that also participated and assisted me with data. And thank you very much for their participation as well, to give you the South African view. Thank you.
Hello again. Thank you very much, Mariet, for this excellent presentation and very thought-provoking data and an evolution of, for example, how child vaccination is also developing and not as a consequence of the COVID pandemic. So there's more ramifications to this pandemic than comes to mind first. We'll continue now with a presentation from Argentina. I'll just... Okay. Trying to change the slide. Oh, here. We will have a presentation by Bettina Caponi. Bettina is the owner and director of an independent community pharmacy in Buenos Aires, Argentina, since 1998. She's the past president of the local branch of the Chamber of Pharmacists of Buenos Aires, which is part of the Argentinian Pharmaceutical Confederation, COFA, who is also an active member of FIP. She's also a pharmaceutical legal advisor and holds a master's degree in integral pharmaceutical care from the University of Barcelona, Spain. Bettina currently serves on FIP's Policy Committee on the Sustainability of Pharmaceutical Services through Viable Remuneration Models. Bettina, it's my pleasure to give you the floor to deliver your presentation.
Well, hello, hi, everybody. First of all, I would like to thank the FIP for the invitation to this webinar and assure you that it's a great honor for me to be here talking with you about the situation in my country.
Bettina, ¿prefieres que diapositivas?
Yes, sí, pero no aparecen.
And just a moment, I will get back
No
control of the slides.
Compartir the slides.
Just a moment. There we are.
Here, okay.
Okay. So you just tell me when you need the next slide and I will pass it for you, okay?
Ah, okay. Yes.
Yeah, thank you.
Okay.
Go ahead. Yeah.
Well, the next one. Argentina is located in South America. The next, please. Can you? It's okay. It's located in South America and measures almost 3 million square inhabitants. Great, please, sorry. Come on.
This one?
No, it's okay, it's okay. That
okay.
one, yes. It's located in South America and measures almost 3 million square kilometers with 44.5 million inhabitants. If we could imaginably superimpose our map to that of Europe we could see that within its surface, we could cover 10 European countries. The next one, please. Argentina is a federal community made up of 24 and 24 independent provinces or states. There are 50,000 pharmacies distributed all over the country. COFA stands for the Argentinian Pharmaceutical Confederation. It is the institution that brings together most of these pharmacies. The next one, please. This is the next one. This is our legal framework, the previous one. As you can see, the first of the resolution of this subject is from 1958, and there have been lots of laws, resolution, and decrees to standardize regularization and equipment, material, registration, and vaccination procedures in pharmacy. The next one, please. Argentinian pharmacists, among our professional responsibilities and duties, hold vaccination and administration of injectable medicines. We have a legal framework that supports us. Our pharmacist offices have a sector exclusively conditioned for this practice, the sanitary cabinet. We cannot measure less than 6 square meters. Walls are covered with special materials to allow its correct and frequent cleaning. Provision of water and service for the collection of residues and waste are also required. Despite the fact that there are different regions in our country with different laws, all of them have adapted these requirements to complete a correct vaccination service. COFA and its local member offices offer the professional different forms and training modalities that include all the updates relating to new vaccines. There is no one specific certification in our countries in this issue, but there is permanent training and updating at the degree certification that is carried out every 5 years that includes every important topic related. The next one, please. Argentina, being such a vast country, pharmacy has an important presence, even in places where there are no hospital or health centers installed. Due to the accessibility, the geographical distribution, the wide working shift hours, and the strong bond of trust that pharmacies have generated among our neighbors, pharmacy has become the most accessible vaccination center to provide this service to the community. The next one, please. Since 2009, influenza vaccination campaign for retirees and pensioners, the next one, please, has been carried out in our country with the intervention of pharmacies. Participation in this campaign is participation in these campaigns is voluntary for pharmacies. Social Security finances vaccines that are distributed to pharmacies, and pharmacies administer the vaccines that advise the population on precaution and care. For this work, pharmacies charge a fee to Social Security. The next one, please. For 10 years, this campaign was carried out uninterruptedly, and since 2017, pneumococcal vaccination was incorporated together with the influenza campaign. Here, you can see how many doses of each vaccine were administered every year. The next one, please. In this slide, we can see the records from the 2019 of influenza campaign doses distribution, the different provinces, and the next one is for the antipneumococcal, the next one, and here's the antipneumococcal of the 13 serotypes. The next one. During vaccination campaigns, it is required to report the event supposedly attributable to vaccination or immunization that occurs. These reports are sent to the National Pharmacovigilance System by fulfilling this form online. Here we can see the sent reports between 2011 and 2015. These reports correspond to influenza vaccination. Let's read one of these examples. Here in 2015, if you can see, over 5 million doses were administered, and just 58 studies were reported for every 100,000 doses, and only 12 related to be serious events. The next one, please. During these campaigns, members freely attended the pharmacist's office where the vaccine administration was flexible and without any shift. Protective measures used by pharmacists were overalls and gloves. The next one, please. As the COVID pandemic is a unique situation, and as pharmacy found ourselves without previous experience to follow, COFA saw the very clear need to outline a series of procedural rules that bring pharmacists close to our new tools to deal with different issues at the times of the COVID. That's why it was decided to write the COFA protocol, an arduous task. Development began in the first days of March, when there was still no standard reference in the country for the new situation. This protocol was based on recommendations published by the FIP, the WHO, the National Ministry of Health, and took as example what was happening in Spain and other countries that have a healthcare model similar to us. The next one, please. As you can see, the first version was finished by March the 13th, when preventive social and mandatory isolation hadn't been decreed yet, and several updates were made until reaching the 7th actualization in June the 12th. We can refer to it, the next one please, as a dynamic protocol modified according to national and international recommendations. It details different guidelines so that the pharmacist can deal with several situations, such as different disinfection of the building, hand hygiene, and cleaning of material and surfaces. The next one, please. Guidelines for the correct separation, signaling, and dissemination of the educational material among the neighborhood. This protocol was installed among the pharmacists, becoming a guide to correct action and procedures of community pharmacies. The next one, please. To carry out the 2020 campaign, standards described in the COFA protocol for vaccination sector were used. In our country, preventive social and mandatory isolation began on March the 20th, an influenza vaccination campaign on April the 1st. Almost a month earlier than in previous years, with the aim of vaccinating a largest number of individuals before COVID cases began. From health authorities, there was a great awareness for older adults and group at risk to come to pharmacies for their vaccine administration with support on TV, radio, and social media network. Priority was given to vaccination for older adults, pregnant women, health personnel, and patients with respiratory disease, diabetes, and immunosuppressants. In order to carry out vaccination campaign this year, according to confinement indications and social distance measures, pharmacies previously established a vaccination schedule by phone or WhatsApp with each patient, taking place at times where there was no public attention or vaccination could be prioritized. Shifts were established every 10 or 15 minutes to respect social distance measures. The next one, please. The number of people who could remain inside the building in every pharmacy was established by protocol. Some kind of marks and signs were fixed in the floor for a better understanding. Everybody else should stay outside, waiting to come in. The next one, please. Taking special care of correct social distance. The next one, please. By protocol, practice of food cleaning was recommended when entering the premises and hand disinfection with alcohol help. Prior to vaccination, each individual was questioned about possible symptoms to rule out case of COVID. After vaccination, administration certificate was given the patient to keep his own immunization records. The next one, please. From COFA, a kit for protection of the vaccinating pharmacist, the next one, was distributed to pharmacists participating in the campaign. The campaign for this year, 2020, hadn't concluded yet. This data I am going to show now are released in late May. As we can easily see, all the numbers have increased. More pharmacies, more doses were administered. I want to highlight that we only have, by the time of this report, 2 months of campaign. And in 2019, it was a completed campaign. You can see here that in 2019, the average of vaccine administered was 4,000 doses, while in 2020, it was 7,200. This indicates that this campaign could be carried out in a few days regarding social distance. The next one, please. Thanks to the numerous and arduous effort of leaders of COFA with government institutions, vaccinating pharmacists receive from the state a pharmaceutical fee for the application that is up to 165 pesos this year, almost 40% of the therapy treatment amount with enalapril 10 milligrams tablet. The next one, please. A survey, the next one, please. Here. The survey on dispenses in private sector, the previous one, the previous. Here. A survey on dispense in private sector of different groups of vaccines, depending on whether they were antiviral, antibacterial, or others, would carried out in February, March, and April 2020. Antivirals are the ones that report the highest number of dispenses, which is absolutely seasonal and dependent on influenza vaccine. In the table, an increase near 70% can be observed if we compare April and May. While antibacterial vaccines have experienced an increase of 13%, in contrast, other vaccines decreases almost 44% in the same period, presumably once social, preventive, and compulsory isolation began on March the 20th, community didn't continue to seek vaccination schedule, especially in children, which constitutes and adds another problem to public health. The next one, please. A further analysis of the 100 most dispensed products on the ethical market show 2 influenza vaccines, both tetravalent, from different laboratories, and the pneumococcal of the 13 serotypes. If we compare the first 4 months of 2019 and 2020, we can see the tetravalent influenza vaccine from one of the laboratories shows an increase of more than 54%. Influenza vaccine from the other laboratory began marketing in our country this year, so there's no possible comparison with the previous one. Pneumococcal conjugate vaccination increased 815% in units. The next one, please. Here, we see a summary of the situation. Here we see a summary of the situation in our country. It is from June the 28th, where the affected provinces are shown. Here you can see the date. The number of the reported, the discarded, the deceased, and the confirmed cases. Within the total confirmed cases, here you have the imported ones, the closest contact, the community ones, and the ones that are under investigation still. On the right, the map shows the distribution by provinces, with the most affected being Buenos Aires, the anonymous city of Buenos Aires, Chaco, and Rio Negro. In the following slide, the next one please, we can see the confirmed cases by age group. The light blue line plots mortality rate for each group. It is important to note that in the case of all adults, we found a low number of cases that we presume may be related to the early preventive isolation, but not a high mortality, but a high mortality rate is shown too. The table on the right shows the decreased cases by age group and sex. Green color represents men and yellow women. Similar numbers of men and women fall ill, but more men than women die. The next one, please. In the COVID pandemic, vaccination campaign could be carried out, where the limitation was always the number of doses available. As the distribution was carried out in station between the deliveries, there was a shortage of doses. Besides, greater number of individuals who were expecting to receive their doses was not and had to be referred to the public system for vaccination. The shortage of doses can be related for the fact that calculation of doses to be purchased every year is always calculated on the dose administered in previous ones. And indeed, this year's situation was atypical. The increased demand because of the COVID pandemic couldn't have been previously foreseen. Despite having lost some vaccination opportunities, either due to the lack of doses or due to the high demand for individuals, the fear in society and health personnel, we can consider this year's vaccination campaign successful in our country, where once again, the importance of pharmacies as vaccination centers has been demonstrated and further enhance pharmacy's social role, not only by supporting and advising members of the community, but also by fulfilling the healthcare agent function as an active member of the health team. I hope that our experience will help colleagues from other countries to implement vaccination programs for the benefit of the global community. Thank you, see you soon. The next one, the next one, please. See you soon in Argentina. Thanks for the opportunity. The next one, please. The next one. The next one. Oh, sorry, the next one. Okay, thank you for your help. Oosh.
Thank you very much, Bettina, for this excellent presentation. It was very clear, it was very comprehensive, and it shows the evolution of the situation of pharmacy-based vaccination in Argentina. And for those of you who didn't know this, Argentina was actually the first country in the world to introduce pharmacy-based vaccination. So a pioneer in this valuable professional service. Thank you very much, Bettina. We will now move to the other side of the world, from early morning to late night, from New Zealand. We invite Andi Shirtcliffe to share some views from New Zealand. Andi is the clinical chief advisor with responsibility for pharmacy strategic advice, policy and planning for the New Zealand Ministry of Health. Andi was the New Zealand COVID-19 pharmacy lead, the ministry's clinical lead for the COVID-19 clinical advisory group, and MMR pharmacy lead. It is our absolute pleasure to welcome Andi to this webinar and to share this, the floor with you. The floor is yours, Andi. Thank you very much.
Thank you very much, Gonzo. Kia ora tātou, ngā mihi nui. Ko Andi Shirtcliffe toko ingoa, ko manatu haora o Aotearoa. A very warm welcome from Aotearoa, New Zealand. I'd like to start this evening by delivering 3 thank yous, if I may. Firstly, to the FIP for hosting this webinar and for bringing pharmacists around the world together to support each other and to share. Secondly, to my colleagues at the Pharmaceutical Society of New Zealand, my colleagues at the Ministry of Health and the New Zealand District Health Boards. As I'm sure everybody on this webinar tonight has experienced, the last few months have been extremely busy, and much has been done at a great speed, and I needed some help to find all of the information for tonight's presentation. But thirdly, and most importantly, I think I'd like to thank my pharmacist colleagues in New Zealand, but also around the globe, for the extraordinary role that they've played and continue to play in keeping people in our communities healthy and safe. The courage and solidarity that's been shown by my peers is truly humbling, and I have never been more proud to be a pharmacist. I'd like to share a little bit about New Zealand and its COVID-19 response, and actually a very brief history of pharmacist immunisation in New Zealand, because that story will explain how what we did through our COVID-19 pharmacist influenza vaccination response, explain how we were able to do what we could do so quickly. New Zealand is a small island nation in the South Pacific. We have a population of 5 million. We are an ethnically diverse and mobile population, and we're a key gateway to the Pacific. That's relevant because alongside our COVID-19 response, New Zealand has deployed staff to the Cook Islands and Niue to help support their preparedness. And also a lot of those Pacific Island nations have to deal with a cyclone season alongside a COVID-19 pandemic. And we've also deployed staff out to those islands to support that cyclone response. In New Zealand, we were, I think, quite fortunate. The virus was quite slow to get here. And so we had possibly more time than some other countries had to prepare. We used that time through February and March to plan for it. We set up a hospital response group to prepare our hospitals for a COVID surge. We worked on a keep it out and stamp it out approach that involved a variety of public health interventions, which I'm sure you'll all be familiar with. Things like physical distancing, testing and tracing, isolating cases and close contacts, and a raft of other measures. We set up a national telehealth response, which at its peak took 15,000 calls a day, which is an enormous throughput for a country of only 5 million people. And we also set up a clinical advice line that was staffed by general practitioners, nurses, and pharmacists. And this was to provide clinical support to, free clinical support to all healthcare professionals. Through that time, a decision was made to go hard and fast and move to an elimination strategy across the country. We developed at central government an alert level framework, which consisted of 4 levels. And at the point that we released this framework on the 21st of March, the public health measures in place at the time were described as level 2. 23rd of March, we moved to level 3, and 25th of March, we moved to level 4. And we stayed in that level 4 total lockdown until the 28th of April. So we certainly went hard and fast as a country, and to date it has been a reasonably successful strategy for us. We are reasonably certain we have no COVID-19 circulating in our community. And although we went for quite a period of having no new cases and all of our cases recovered, we now have 22 active cases, all of whom have been from New Zealanders coming home and are in isolation facilities. So flu vaccination, pharmacist flu vaccination in New Zealand started in 2012. The flu vaccination was reclassified to enable pharmacists to administer to people over the age of 13 years, and it was made available in the private market. Several attempts were made to get government funding, and the main barrier that was put forward for enabling public access to public funding, pharmacist access to public funding, was there was no way for pharmacists to upload the information to our National Immunisation Register. The argument was made by many parts of the health sector that this would lead to fragmentation of care and fragmentation of data. So because as a country we weren't getting coverage rates in the vulnerable populations that we sought to and thought were desirable, the ministry decided to fund a web-based portal which enabled pharmacists to upload their vaccination transactions up to our national register. That was in 2016. In 2017, another bid was put up for government funding, and that was granted for pharmacists to be able to give publicly funded flu vaccines to pregnant women and people over the age of 65. Part of the implementation for that process required us to work with our national drug funding agency, PharmAC, to make a change to our pharmaceutical schedule, which enabled a funding mechanism. And we also worked with our district health boards to add an appendix to the national pharmacy contract, and that enabled a contracting and the other part of the funding mechanism that was needed. So to recap, in 2016, we had 300 pharmacies out of a total of about 1,000 providing flu vaccines in the private market. In 2017, we had about 600 pharmacies who had taken up the option to have a contract, but only about 200 of them were providing flu vaccines in the public market, so only 200 claiming. Fast forward to 2020, we have 800 of our 1,000 pharmacies with a contract. And although our data is not totally up to date at the moment, I have overwhelming feedback both from the sector and from our funder that all pharmacies are claiming. So the 2020 COVID-19 pharmacist influenza story in New Zealand. Well, we started off at the end of last year, as previous speakers have said, that we were ordering our stock in December like everyone else. Normally, we would have ordered in 1.2 million doses. This year, we actually ordered in a total of 2.12 million doses. Firstly, 1.76 million. We wanted to have a push to increase our coverage. Of course, we didn't know about COVID at that point. When we realised that COVID was becoming a thing, our drug buying agency was extremely successful in getting us another 360,000 doses for our country. We decided to start our flu season early. Normally we'd start on the 1st of April, but this year we brought it forward to the 18th of March. And from the 18th of March through to the 27th of April, we chose to prioritise all of our stock in New Zealand to eligible consumers in the community, so those pregnant women over 65 and people with long-term conditions, plus healthcare workers and emergency response workers. We made a policy decision at the Ministry to widen pharmacist vaccination to all eligible populations over the age of 13. And we were able to widen this pharmacist access relatively easy because in 2017 we had already enabled a payment mechanism, and all we needed to do was make a minor change to the contract. At this point in time, this was in the latter part of March, all community pharmacists were exceptionally busy dealing with and managing quite a lot of panic ordering of prescription medicines. So we enabled the contract acceptance process to be really easy. We emailed the contracts out. We didn't expect people to sign them and send them back. The post was pretty disrupted anyway, so that really was going to be quite difficult. All the pharmacists needed to do was process a claim for one vaccination, and the contract was deemed to have been accepted. We made a decision to increase the the vaccination fee by 2% for all vaccinators. And all of these steps were implemented from a government level by the beginning of the last week in March. So if you remember, on the 25th of March, in that week, over a period of 4 days, we shifted from level 2 to total lockdown. And at that time, our general practices across the country moved to almost totally virtual service provision. So that meant that community pharmacies in the New Zealand healthcare system were the only community-based healthcare provider who was out there in the community permanently with their doors open. So we got it there across the line just in time. We did a few other things to support uptake of pharmacist influenza vaccination services. We built a free online vaccinator training portal and training. This lasts 2 years and covers influenza, MMR, because we're about to start an MMR catch-up campaign. And should we be fortunate enough to get a COVID vaccine, then it will cover that as well. We enabled clinical assessment for the training to be undertaken by any pharmacist who has been vaccinating for 2 years. Previously, this would have had to have been by an accredited clinical assessor from our National Immunisation Centre. The Pharmacy Council, who is our regulator of pharmacists, gave an extension on expired CPR certificates. This was based on the rationale that even non-vaccinating pharmacists under their scope of practice are relied upon to deal with emergency situations, so the risk was deemed to be minimal. And at the Ministry, we commissioned our National Immunisation Centre to revise the risk-benefit of the vaccination service in light of the extraordinary circumstance that COVID presented. This risk-benefit analysis changed some of the criteria for the service. So patients only needed to stay 5 minutes in the pharmacy, 5 minutes post-vaccine, not 20 minutes as was previously required, so long as the people met certain criteria, which most people would. And it also deemed that it was no longer required to have portable oxygen on the premises. This was seen to be a barrier to implementing the service, and acknowledged that severe allergic reactions to influenza vaccines are extremely rare. So all of this implemented in a COVID environment meant that the experience of getting your flu vaccine at a community pharmacy looked a bit different as well. My experience of taking myself and my daughter, who are both asthmatics, into our local pharmacy was an extraordinary experience, and I was truly proud of my colleagues. Previously, it would have been a walk-in service, but a booking option was introduced. Triage and consent and consultation occurred over the phone before I'd even left the house. We were actually only in the pharmacy premises for 5 minutes. And as it was totally government funded, there was no need to handle cash, which we all know is an infection prevention risk in these times that we find ourselves in. And I have continued in my role to have a lot of feedback, both from my colleagues out in the sector and also my health official colleagues, hearing things like, we have hundreds of examples of people who came in for another reason and left with a flu vaccination. And pharmacists saying, I have vaccinated people who have never had a vaccination in their lives. So one last learning that I'd like to share before I wrap up is just in the hope that others can learn from some of the unintended or unexpected issues that we experienced with our supply chain. We did experience some lumpy distribution, some uneven distribution of stock, which needed some intervention. We found that there were some significant automatic back orders in our system that were automatically filled out to occupational health services who were providing in the private market. So we needed to intervene to redistribute that stock so we could redirect it to our vulnerable patient groups and our emergency response workers. And also wholesalers had a protocol of supplying on a first come, first served basis. So we engaged with them to prioritise and be a little bit more strategic as to how stock was and to who stock was released. And it won't be any surprise to anybody on the webinar this evening that in general pharmacies were caught out less by stock distribution issues than general practices across the country. So that shares a little bit of from the central government level of the things that we put in place to drive rapid uptake and remove the barriers to enable pharmacists to be stepping up in this hugely valuable health intervention during COVID. So thank you.
Thank you very much, Andi, for excellent presentation as well. I think we've had the privilege of listening to 3 different experiences, and I really appreciate and that you took the time to share your expertise. And I must congratulate you, because I'm sure that in your role in the Ministry of Health, you've had something to do with the success of this experience of pharmacists in improving vaccination coverage during the pandemic over there. So thank you very much. I will now open the floor for questions. Well, the floor has been open for questions throughout the beginning, and we have received a number of them. I will invite the other speakers to open their cameras as well, and I will address some of these questions to either all of you or a specific speaker. The first question is concerning the second wave that everyone is talking about of the COVID pandemic. Is it, no, I believe, well, it doesn't say. Is it caused by the drift of the actual circulating virus strain or a total shift? In each case, what would be the efficacy of the vaccines everyone is working on now? So it's definitely about COVID-19. I would perhaps address this question to Andi. Would you like to comment on this?
I hope I've understood the question properly. I think from a New Zealand...
Should I repeat the question or read it again?
That might be helpful, thank you.
Sure. So concerning the second wave of the pandemic that everyone is talking about, COVID-19, is it caused by the drift of the actual circulating virus strain, or is it a total shift? In each case, what would be the efficacy of the vaccines that everyone is working on now?
So I think from a New Zealand context, I think we're expecting that if that a second wave for us will be as a result of virus coming into New Zealand across our border. We have been able to shut our borders down quite tightly. I'm not familiar with whether there has been a total shift in vaccine in the context of whether there's been shift in mutation. So it would be hard to make comment on the vaccine effectiveness of the different vaccines that are being worked on around the country, around the world. So yes, from a New Zealand perspective, I think that we would be expecting a second wave to be from a shift of virus coming in from overseas across our border.
Thank you, Andi. Another question is there now a mechanism in place to ensure that mandatory vaccination of all healthcare professionals actually happens? I believe this question was addressed to Mariet, because you mentioned that this was one of the developments that happened in South Africa. Mariet, would you like to comment on this? Is there a mechanism to verify that healthcare professionals are actually vaccinated?
And thank you, Gonzo, and thank you, colleague, for the question. As I mentioned, this is the first time that this was actually mandatory to have healthcare professionals. You know, previously it was a good option for a healthcare professional, but it was never mandatory. So, and we should keep in mind that it was made mandatory, you know, in March 2020, way after our influenza vaccines were procured. So I've got to be honest with you that I don't know if we even had enough vaccines available. I know one of my colleagues shared that some of the pharmacies couldn't even procure enough vaccines only for the pharmacy staff, you know, not to mention the public or the patients. And so one needs to keep that in mind, that the number of vaccines that were available in South Africa were maybe not sufficient. So I can't confirm that every single healthcare professional were able to get a flu vaccine, although it was healthcare professionals were listed as those individuals that should get it. Is there a way to monitor it? Definitely not at this stage, I believe, because it was, you know, I think that we are living in such uncertain times, and going forward, I think this is something that both the public and the private sector can build on going forward. But it wasn't something that was initiated and immediately there was some sort of registration or a way that it was monitored. But I believe healthcare professionals do understand that it was done for their benefit. So yeah, I think going forward, I think this is something we can keep our eye on, Whether it will be continue to be mandatory in years to come, I also don't know. I will be speculating if I have to answer that.
Thank you very much, Mariet. We have a brief survey now on the screen, so I'll just give you a few seconds if you can kindly respond to that. And in the meantime, I will, we have a question. Hello, what conditions does a pharmacy have to fulfill in order to have the right to vaccinate? For example, in terms of space requirements, or is the pharmacy remunerated for the service? And with respect to our speakers, I would just like to take the opportunity to share with you that FIP launched last week a new publication that addresses this and other questions and supports pharmacists in introducing pharmacy-based vaccination in their countries or at wherever, of course, the legal framework allows, and describes the space requirements and the technical requirements for developing or for offering this service. Thank you very much for responding to this question and for the high grade of the high rate that you have given to this webinar. Okay, we have several other questions coming in. Given the significance for getting large numbers of people vaccinated, has the government reconsidered its restrictions for pharmacists to administer vaccines in the public sector? Maybe Bettina, would you like? So considering the significance or the importance of getting large numbers of people vaccinated, has the government reconsidered its restriction for pharmacists to administer vaccines in the public sector? Or maybe Mariet, would you like to address this, since it also mentions this situation with the public sector?
Yes, I think I show some of the reports from the public sector in our country. The government allows us to administer vaccinations in the public sector too. We only need to have the prescriptions, and if they are available, you can be vaccinated in the pharmacies. At the same as when Mariet experienced, the vaccines were few in our country, but because of the demand of this year. I think that it's very important that the governments all over the world reconsider this position, because as we see, as we can confirm in our country, the pharmacies are very, very close and very easy for the people to get vaccine, and they trust very much in the pharmacists, so they can come and ask you for all the evidence and all the questions. And besides, in this moment that they don't have to get to the health centers care to protect themselves, it's better to come to our places. So they have to be reconsider these things all over the world. That's my opinion.
Thank you,
Bettina. Yeah, go ahead, Mariet.
Thank you, Consa. Yeah, if I can add to that, I've mentioned that in the public health sector, it's predominantly a nurse-driven service that's offered. And yes, the government could consider, increasing or involving pharmacists in this duty. But I think this is maybe not an easy or a straightforward answer, as the public sector, and our public healthcare facilities are very overburdened with different tasks and the way they service patients. So if you want to put forward that pharmacists could assist in the vaccinations in public health sectors, one should keep in mind that it might cause an increase in workload for the colleagues in the pharmacy that's remaining to do the dispensing and counseling of patients. So definitely, as we move forward into universal health coverage, we as pharmacists will offer our services to the National Department of Health in any way. But in a universal health coverage model, I think it will be more easy to get a more even distribution of those patients across healthcare settings. And it could be that a private healthcare facility, a pharmacist there will be offering a service to a public healthcare sector patient with public sector stock. So that is definitely, I know in some of our provinces that's already the case. So definitely something that we need to work on and to keep in the loop and to take up with our government going forward.
Thank you, Mariet. We have another interesting question that maybe the three of you can comment on. Are patients hesitant to come into the pharmacy or to their medical provider offices to get vaccinations, whether flu or other vaccines? What strategies have you used to overcome this hesitancy? Mariet, would you like to start?
Yeah, thank you. So I think it's normal, and I would be interested to know what my colleagues is also saying, but I think it's normal that we found patients that were hesitant to come into healthcare facilities. But also during our initial level 5 lockdown that lasted for 5 weeks in end of March and April, our colleagues at pharmacies throughout reported that they were extremely busy. So during that time, the public or patients were only allowed to access healthcare and to buy essential goods like food or, etc. So our colleagues in pharmacies were extremely busy. So although I believe there were people that were hesitant to come, there were other colleagues that came. And I think it was also fueled by a need for information and a need for clarity. Uncertainty really caused fear. So there were a few things, and to report maybe on a strategy in terms of immunization. I think pharmacists are well trained in being professional and for keeping a hygiene approach when it comes to offer a patient service. So the things like washing of hands and wearing of gloves when an immunization is taking place, those type of things, I think pharmacists are already used to do. So I don't think there was a massive change for pharmacists in offering these services. Obviously, there were a few more maybe precautionary actions that were added. But essentially, I think there was people, and I've indicated that our statistics shows that there was a decrease in access to immunization. Maybe this was by patients that were maybe feared or thought maybe the vaccine wasn't necessary at that stage. They will always access it at a later stage when maybe the whole issue of the coronavirus and our lockdowns is maybe reduced, although there were other people that continue to access the services that they did need during that time.
Thank you, Mariet. Bettina, would you like to address the same question?
Yes, I really agree with what Mariet said. Because we have, again, the opportunity to be just there, just in hand. The people have us just in our pharmacies, so we are always there to be on their side. They need to talk, they need to be content, they need to be explained. If you can do it all that every day, they can wait, they are going to be prepared by phone, by messages. We have implemented all the media communications because people try to get information from everywhere. So I think we have to be there to give the correct information. And if we can keep the people, keep our neighbors informed and contained, they are going to wait, they are going to calm down, and we can pact or take account on when can they come to get their vaccines or their medication, and we can give them a little of pace that we don't have these days.
Thank you very much, Bettina. And finally, Andi, do you have any experience of how New Zealand pharmacies address this patient hesitancy to come to the pharmacy and be vaccinated?
I think the person who asked this question is correct. There has been in New Zealand some hesitancy to go to pharmacy. Pharmacy hasn't historically been seen as a vaccinator in New Zealand. I think that's been slowly changing. Our pharmaceutical society has put together some social media material to to start to change the way people view pharmacists and pharmacies in this area, and in a number of other new services that pharmacy provides. I think it's also a generational thing. I think that the younger generation see the walk-in ability of the community pharmacy as convenient, and it suits their lifestyle. I will be interested to see in New Zealand if there's quite a marked change in that, because in our lockdown, with general practices going almost totally virtual, pharmacy was the place that people went, and we might see that that change in the way the population sees pharmacy and vaccination has been sped up.
Thank you very much, Andi. We now have the third and last question, I think, with regards to the webinar and your assessment of the webinar itself. And in the meantime, I will ask possibly the last question out of time. And this is a question to any of the panelists as well. What were the challenges, if any, in administering vaccines in remote, rural, or historically underserved areas? Were there any steps taken in your country to significantly increase access to health service provision? And maybe this time we'll start with Bettina, probably because of the size of the country and the extension of rural areas. Bettina, were any specific measures taken to reach out to underserved areas or rural populations or remote areas?
Yes, here our government made up a kind of campaigns, and they were going to their places. They made some kind of bans, and they went, they said home by home, door by door. So they went to their places because they are very far, or when there are people who that cannot come, or that they are restricting from movements. So they went to their places to vaccinate, so as to get the largest number of people vaccinated as quickly as possible. And I think it's a good idea, it's a good method. So you have to assure yourself that you can vaccinate everybody, the most people you can. This is some of the ways we did it here.
Thank you, Bettina. And Mariet?
And thanks, Gonzo. Yeah, I would like to, I agree with Bettina from Argentina. And so in South Africa as well, I mean, this will always be a constant initiative or a constant effort to find our rural areas and to make sure that our more rural areas have access to services. So that's also a continuous effort in South Africa to ensure that every citizen has access to healthcare services. Also during our level 5 lockdown, the government rolled out screening services, but that was obviously focusing on COVID-19. But I think that it was an opportunity also to interact, because those services also, that screening services also went home to home. And what one should keep in mind is normally when you go home to home during the day, people are at work. And now during the level 5 lockdown, everybody was at home. So it was much more effective in reaching people because they were actually at home. Everybody had time to listen, and maybe had for the first time in a very long time, the opportunity to go and access the healthcare facility to get that needed vaccine. Because normally they were working very long hours during the week, and over the weekend maybe this facility wasn't accessible. So those type of interventions, I think, did take place, and it was an initiative to especially reach that rural areas. Although I don't think you can solve that problem in one shot, but it is definitely an improvement, and one should continue to improve those type of efforts.
Perfect. Thank you very much, Mariet. Andy, do you know of any strategies implemented in New Zealand to reach out to rural areas and underserved populations?
The things that I am aware of, we had mobile CBACs, community-based assessment centres, that were going out into rural and remote locations. Now they were doing testing, they weren't doing vaccinating, but they were doing health promotion, information provision in those areas as well. Our community pharmacies are very well geographically spread across our country. And so we've got some New Zealand-based research that I think if it's not just been published, it's about to be, that signalled that the key barrier to vaccinating in some of those rural and remote locations from the health professionals is their ability to get to training, because they can't get replacement and locum staff. So I think the online vaccinator training that we provided for free has seen quite a high uptake in some of those more difficult to access communities. So we don't have any evaluation or feedback on the extent to that, but I think that certainly specifically addresses a finding that we knew was coming through in the research. And I do know that when we had a meningococcal W outbreak in the very far north of New Zealand, we used a mix of health professionals and mobile cold chain to take vaccinations out into Māori communities. I don't know that we have done that with flu during COVID, so I don't have any detail on that aspect. We can't hear you, Gonzo.
Oh, sorry. I was just saying thank you very much to all three of you, and I apologize that we are 1 minute over time. But I thank everyone for remaining until the end, active, and thank you all for your questions as well. And finally, just as a wrap up, I think that it is really imperative for countries to consider to invest and expand vaccination programs that address the adult population mostly, and include the flu vaccination and increased coverage for vaccination against the seasonal influenza, because we see that if another burden, another wave of COVID-19 comes our way, it is important to prevent the co-infection. It is important to reduce the burden of respiratory diseases, and so pharmacists, what we see from these three country experiences that we have listened to during this webinar is that pharmacists can really be valuable partners of broad health strategies in reaching out to more people and increasing vaccination coverages, not only for flu, but we're specifically talking for flu. So thank you very much for sharing these inspiring presentations and experiences, all from the global south. And we trust that colleagues from the global north and also in other countries in the south also learn from these experiences and are inspired by them in implementing such services and strategies in their own countries. So thank you all very much. It's been a pleasure moderating this webinar, and I hope it was valuable for you as well. Thank you. And oh, by the way, my colleagues asked me to remind you that you will be receiving an email tomorrow in 24 hours with a survey and a link to the webinar. And soon the webinar will become available on the YouTube channel of FIP and also on the FIP Facebook page and our online library on the FIP website as well. And finally, I would like to thank my colleagues, Mila, Daria, Ali, and Carola for their magnificent effort to organize and promote this webinar. Thank you all very much. And to our speakers, a very big thank you for your time and expertise. Goodbye. Thank you very much.
Goodbye.
Bye-bye.